Xolani Gwala on 702.
For the curious.
Live.
Online.
Streaming on 702.co.za.
DSTV.
And 92.7.
And 106 FM.
It is 5.5 minutes after 12. A very good afternoon to you. It is Friday, the 19th of October, and you're listening to the Xolani Gwala show here on 702 and Cape Talk. We're coming to you live from our Johannesburg studios. Well, coming up on the show then this hour, how much do we know about the prevalence of cancer, all kinds of cancers in South Africa? What are the risk factors that are exposing all of us to these kinds of cancers? What prevention methods, screening and treatment programs are available to deal with the cancers? Are they affordable? And critically, is our healthcare system, particularly the public healthcare system, geared towards dealing with what some, including the Minister of Health, have referred to as an epidemic? Is the healthcare system able to deal with this epidemic then? These are some of the questions that we will try and get answers to over the next 54 minutes here on the program. But of course, as always, I am looking forward to hearing from you around this issue of cancer. Here are the numbers. You can give us a call on 011-883-0702 or 021-446-0567. Send me a text message at 31702 or 31567. I'm also available on Twitter at GwalaX, or send me a voice note on 072-702-1702. Please keep your voice notes very short so that we are able to play all of them, or at least as many as we possibly can. Keep them short, identify yourself, and get to the point, straight through to the point, and be engaged and be involved. All right then, let me introduce you to the people who will assist us in terms of answering some of the questions. Let me start with the Deputy Director General at the Department of Health, who joins us on the line this afternoon, Dr. Jürgen Pillay. Dr. Pillay, good afternoon and thank you for your time.
Good afternoon, Xolani, and good afternoon to your listeners and fellow panelists.
Thanks indeed for coming through. All right, here with me in the studio, let me welcome Chiara Bergstrom, Head of Research and Complementary Care at Netcare Breast Care Center of Excellence. Chiara, a very good afternoon to you.
Hi.
Thank you for coming through. I'm also joined by Professor Michael Herbst, who is a health specialist at the Cancer Association of South Africa. Professor Herbst, good afternoon.
Good afternoon to you and all the listeners.
Thank you. Dr. Ryan Noach is Deputy Chief Executive Officer at Discovery Health. Dr. Noach, I beg your pardon. Thank you very much for your time.
Thanks very much for being here.
Much appreciated. Adri Ludik is Awareness Program Development Manager at CHOC. Adri, where's Adri? Adri is over there. Good afternoon to you, Adri.
Good afternoon to you and the listeners.
Thank you for your time. All right, then, I'm going to come back to my guests in a moment. But according to the Cancer Association of South Africa, about a quarter of the South African population are personally diagnosed or have a loved one, family, friend, or colleague with cancer. Now, let's do the math. There's 57.5 million of us here in South Africa. And if the Cancer Association statistics are anything to go by, there are at least then 14.5 million people who are either affected or infected by cancer. And anecdotal evidence suggests that this may be true. Take our floor alone, second floor here at Prime Media House in Johannesburg, which is where 702 and EWN are, right? And I'm not talking about the entire building. I'm not talking about the entire company. I'm talking just about second floor. There are at least a dozen people who have directly been affected by cancer. And take a listen to the audio that I'm going to play for you of our colleagues talking about their stories. Last September, I was diagnosed with stage 4 cancer and have been fighting ever since then. My name is Xolani Gwala. I'm a presenter on Talk Radio 702 and Cape Talk. When I was diagnosed, I was probably one of the fittest guys in the office. I ate very well, I didn't smoke, I didn't drink, but still, I was diagnosed with stage 4 colon cancer. And I've seen it even here at work at 702. I can give you over a dozen people who have either been directly affected by cancer or have relatives who are still battling cancer, and in certain instances who unfortunately have passed on because of cancer, and they will be giving you their stories.
I'm Karima Brown. I'm the presenter of the Karima Brown Show, which is a specialist politics show on 702. I'm on air from Mondays to Thursdays. I lost my mom to breast cancer when she was 50. My best friend to cancer of the stomach lining when she was 34.
I'm Lita Mbondwana. I produce the breakfast show on 702. My father passed away from the disease.
My name is Nkateko Mageza. I work at the help desk as a help desk assistant. My beloved dad passed on. He had prostate cancer.
My name is Tara Penny. I am the EWN afternoon news anchor on 702. My father passed away from lung cancer last year. My aunt came over from Ireland to help us look after him for about a month. And then she returned to Ireland and a few months later also died of lung cancer.
So my name is Jonathan Kabazela Fairbairn. I'm a producer at 702 as well as an on-air contributor. My mother, who was diagnosed in 2012 with non-Hodgkin's lymphoma, and other family members as well, such as two of my uncles.
My name is Aurélie Kalenga. I'm a breakfast news anchor for Eyewitness News. I lost my sister to breast cancer.
And my sister-in-law to colon cancer, and she was 51.
Currently, my sister, Emily, has breast cancer.
So I've had quite a few people who mean a lot to me die of the disease.
Firstly, there's a massive issue of access to treatment. Not many people have access to treatment. In fact, if you're not one of the 16% in this country that have medical aid, treatment is almost always impossible for you.
My mom hid the cancer from us as her children, and those were in the days before HIV was the new stigma. It was also because she was a working class woman. She was a factory worker. She didn't have medical aid. She couldn't afford the cancer treatment.
From what I understood from back then already was that treatment was quite expensive.
My sister was treated in a public health care facility. I am aware of how expensive treatment was.
They used to part with around 4,000 rands a month to get that injection.
With regards to my mom's treatment, fortunately she had medical aid. Unfortunately, the medical aid did not pay all of the funds.
In the government sector, you have to wait a lot longer. So if you want help quickly, then you have to go private, but that's only if you can afford it.
Very few public sector hospitals have the capacity to give the treatment that you need. And I think that we need to mobilize society, but also appeal to the public sector and others who can help us influence the policy around the issue of treatment of cancer patients in the public sector.
I think from what I see, there's still quite a lot of obstacles people face in accessing healthcare.
Because you are unlucky enough to be diagnosed with cancer, I don't think it should be a death sentence because you don't have the financial means to cover the cost.
Being ill is regarded as a liability. How can we still have outmoded ways of dealing with this disease? This disease needs a complete overhaul.
Cancer equals death, according to what we have been told all the time. It's only now that we know that cancer can be beaten.
Dr. Jürgen Pillay, these are stories from my colleagues here at 702. I understand that government has got a registry for cancer. Can you give me a sense of the numbers of people that are infected by cancer in particular in this country?
Thank you very much. So yes, we do indeed have a cancer registry, and we've had it now for about 2 decades. The latest numbers that I can quote you are twofold. One is a projected number by the International Agency for Research on Cancer. They estimated that in 2012, we should have been able to pick up and screen, diagnose, treat just over 77,000 new cancer cases, patients with cancer in 2012. In 2012, in that same year, in the cancer registry, there were 37,632 female patients with cancers reported. And if you look at the numbers between males and females and the different types of cancers, with respect to breast cancer, there were, in that year, 8,203 new patients with breast cancer reported for the first time in 2012, 5,785 patients newly diagnosed from a lab with cervical cancer, and 6,807 men with prostate cancer. So as you can see, the projected number by the International Agency for Research on Cancer is about double what is currently, at least in 2012, what was reported through our lab-based cancer registry. So we've been trying to obviously improve the cancer registry, but the cancer registry itself is not the only problem. The issue, of course, is that we need to ensure that we screen a lot more people, screen early, diagnose early, and treat early.
Sure, but I do need to talk about the registry, because you can't treat it unless you can measure it. You've got to understand how big the problem is before you even talk about screening, treating, preventing, and whatever else.
No, I absolutely agree. So we've been working with the National Health Laboratory Service, who runs the cancer registry for the country, including in complementing the lab-based registry with a community-based registry. So we've started 2 community-based registries to get a more robust sense of the numbers, because you're absolutely right, we must be able to measure.
Sure.
So we're going to be complementing the lab-based registry with a community-based registry.
But the takeaway from what you're saying, Dr. Pillay, the takeaway from what you're saying is that actually government doesn't quite know the extent of the problem in South Africa at the moment. Government doesn't quite have the statistics.
No, I'm not saying that at all, Xolani. All I'm saying is that we have a projected number by the International Agency for Research on Cancer, and we have a lab-based report on the number of cancers by type and by gender reported through the cancer registry. So we've got that data.
Okay. All right. Let me just come back here in the studio and perhaps bring you in, Professor Herbst, from the Cancer Association of South Africa. Do the Department of Health statistics tally with what you know, with what you have?
I haven't got the 2012 registry, and I can't understand why Dr. Pillay is quoting from the 2012 registry for us, because we already have a 2014 registry. And according to that, they say that there are about 74,000 people, men and women, who have been listed in the registry, and it's a pathology-based registry, so it only includes people for whom a biopsy was done and sent to a lab and confirmation of cancer. But I had access to interesting international research during the last 2 weeks. Yeah. And it's about 50 international researchers, and they did research throughout the world. And according to them, in 2015, South Africa had just over 114,000 patients diagnosed with cancer. And, the figures don't tally.
And again, let's just clarify this. When you talk about 114,000, are you talking about 114,000 per year?
That is for the year of 2015.
Oh, right. So that particular year only. Ryan, let me bring you in as Discovery. We covered a story a couple of weeks ago here on this program, and part of the story was that Discovery is applying, if that's what you do, for an increase in the premiums, partly because you're seeing an increase in the number of people who are claiming for cancer in particular. Tell me what you're seeing.
Yeah, thanks very much, Xolani. It's absolutely true. Over the 6 years from 2011 to 2017, we've seen a 45% increase in the number of people receiving treatment whilst on Discovery Health Medical Scheme. So that's a prevalence figure. It's the number of people that could be on treatment at any point in time. Could be the first year or the 5th year of their diagnosis. But there's been a 45% increase in prevalence over the 6 years. The medical schemes industry in South Africa, the private sector, is not necessarily representative of the country's cancer prevalence. The reason is because we have something called anti-selection in medical schemes. If you're sick and you are on the border of affordability prior to being sick, you're unlikely to join the medical scheme. If you're sick, you're quite likely to join a medical scheme and try and secure cover. And so we tend to attract a higher risk population, older population as well. And as a result, we have a higher prevalence in medical schemes in South Africa than that of the entire country. But I can tell you that the prevalence in Discovery Health Medical Scheme at the moment is that there are about 40,000 people out of the 3.5 million who are currently receiving cancer treatment, which represents about 1.4% of the insured population on Discovery Health Medical Scheme.
Okay, I'm going to come back to, and I've got one or two emails, particularly about Discovery. But Kiara, I want to bring you in here because breast cancer, as I understand it, is one of the more prevalent in South Africa.
With women, yes, that and cervical cancer.
Yeah.
In South Africa, 1 in 29 women will be affected with breast cancer.
And what I have experienced personally going through chemotherapy is that the patients are getting younger and younger.
Yes. We see a lot of young breast cancers. There's a misconception that it's an old woman's disease, yet we see ladies in their 20s and being diagnosed with breast cancer.
Right. Let me just go back and I'm going to open the lines now. Take the calls on 011-883-0702 and 021-446-0567. I want to go back to Dr. Jürgen Pillay. And this is the reason why I come back to you, Dr. Pillay, then is having heard what my other guests are saying, clearly we have a problem in our hands. But the question is whether or not the healthcare system is geared towards dealing with this problem.
So we recognize the increasing rates of cancer over the last 3 or 4 years in particular. And we have done a number of things to start gearing up the health system to deal with the cancers. And clearly, one of the things that we do know that between 30 and 40% of the cancers are amenable to lifestyle issues. And we have been dealing with that through our PILA campaign. And, those are the obvious things of the way people eat, overweight and obesity, alcohol, smoking, excess processed and red meats, and lack of dietary fiber. So we do know that, and we've been dealing with that through our PILA campaign. Those are the risk factors for the non-communicable diseases in general. With respect to the health system, because most people are interested to know, so how's the health system geared up?
Yeah.
We, Xolani, have done an audit last year. We completed it last year of resources, both doctors, nurses, radiation oncologists, radiation therapists, etc., together with equipment needed, especially radiation equipment, to look at what exists in the public and the private sector and to look at where the gaps are and where the oversupply are in order to refashion the service delivery platform for medical and radiation oncology services. And what it tells us, of course, it's told us where the gaps are. And I think patients, when they call in, also identify gaps. We know, for example, in Northern Cape does not have any radiation oncology services. Those are provided on a referral basis to the Free State, and similar with Limpopo and Mpumalanga on a referral basis to Gauteng. Now, the audit that we did has been used to develop a business plan to send to our National Treasury, because we need another R1 billion to strengthen this medical and radiation oncology services in the public sector.
All right.
So we have quantified it, and that's really what the proposal is. In the meantime,
you need R1 billion, and I was just going to go to some of the information that is now public about the audits. I mean, if you go to KZN, for instance, and everybody has been talking about the situation in KZN, where at some point you didn't even have an oncologist. There were problems with radiation. In fact, I think it was Carte Blanche last weekend that reported that there is a backlog of at least 8,000 patients who are still waiting to be treated in KZN. Now, the problem with this is that, and I'll say it from a personal point of view, if you had said to me, wait for 2 months before you start treatment, I'd be dead.
No, that is true. That is true. And KZN, to their credit, recently have done things to improve access. For example, with help from the National Department, we've put in a new linear accelerator in Addington Hospital, as well as fixed the second one. And they have procured the services of this health consortium to provide the oncologists and the radiation specialists at Addington. So the problem is being resolved. We will soon be announcing the results of a tender that we issued to get the private sector involved in providing radiation oncology services, especially in KwaZulu-Natal and Gauteng, to deal with the backlog. So we are working on that, and the Minister on the 31st of October will be launching a national cancer campaign, during which he will list the large number of things that we have started and will start doing to address the problems across the continuum of care, from screening through to palliative care.
All right. I'm going to let you go just in a moment and then come back to my other guests in the room. But I need to read you a message that's come through from a doctor. This doctor wants to remain anonymous. It says, and it's quite long, so it's got a number of points that I'd like you to respond to. It says, radiation is an important part of cancer care. However, it's no secret the sophistication of it means expensive machines and highly trained oncologists, and that's not easily accessible in remote areas. It's no secret there's a crisis after KZN and CMJAH were in the news and under investigation by the South African Human Rights Commission. Somehow, when the hype dies down, all those promises made fade away. It's just that there are people that on any given day, it is the most important day of their lives. And this is the point I was making, that if you had said to me 2-3 months down the line, perhaps I would have died. And somehow the urgency to fix things is lost because the same people who cause the problem are expected to fix it. They never leave, and so the problem remains. They make sure you never dare raise your voice with gag orders. It is collapsing literally and figuratively, and no one gives a damn. Is it because if you're poor, you'll remain invisible? That's what it feels like. Cancer is haunting, and yet the technological advances have given us chances to do so much, like make a stage 4 colon cancer curable. However, the doctors are driven away, and the training of such a sophisticated speciality is then lost, and a vicious cycle ensues. Sad to say, but with cancer you can always blame the cancer for the patient's death. No one will be held responsible. There will be no witnesses. That's clearly the message that we're getting, all of us. That's a very long message from a doctor who clearly is despairing, Dr. Jorgen Pillay.
No, I appreciate what the good doctor has said, and that's precisely why the president has called a health summit, which started this morning and will run through to tomorrow, with stakeholders from civil society, the professional groups, the private sector, provincial governments, led today by the deputy president, who's just finished speaking, actually. And the critical thing that's been raised is that if there are challenges in the health system, in any part of the health system, we must look at the entire health system. And clearly, our health system as a whole needs strengthening. And the Deputy President, in his speech this morning, raised issues of governance and leadership, raised issues of infrastructure and equipment, raised issues of human resources, and raised issues of monitoring. So those are the 4 critical issues that the Deputy President, together with financing, of course, raised this morning. And the 2-day summit is supposed to come up with very practical and concrete responses to those 5 challenges that I've outlined.
All right, Dr. Jorgen Pillay, please hold the line. I need to take a quick break. I know that Dr. Ryan Roach wants to respond, and I've got a couple of messages that are coming in, but let me take a break first.
With a revolutionary design situated in the heart of Sandton, the Mark offers shoppers convenience, high street fashion, and a selection of fine dining options. If you're a corporate connoisseur working from any location, the Mark offers you the best in coffee from Starbucks, Seattle Coffee Company, Bootleggers and Tashes. The Mark boasts fluent fashions such as Dash Men and Ladies, Envy Couture, Levisons, Tread & Miller, Exception and Cape Union Mart. If success had an address, it would be the Mark on Maud and Rivonia Corner.
Selling your car? CarZar will get you more ZAR for your car, more levy for your Chevy, more jam for your van. Go to carzar.co.za for an instant quote today.
It's in moments of change that I remember how important my family is. I'm at ease knowing that should I become permanently disabled or pass away, Liberty Medical Premium Protector will be there to help us continue accessing quality healthcare by paying our medical scheme contributions for up to 10 years. And that means future moments like Grade 1 Gold Stars or graduations are given a better chance. Search Medical Premium Protector or speak to a Liberty financial advisor or broker. Liberty Group Limited is the insurer of Lifestyle Protector and an authorized FSP. T's and C's apply.
The Xolani Gwala Show.
Xolani Gwala Show
on 702.
All right, the show today looking at the cancer epidemic in our country. What can be done? What are the risk factors that are exposing us to all of these kinds of cancers? What prevention methods, screening, treatment programs are there? Is our healthcare system able to deal with this issue? And I've got guests in the studio, but on the line, Dr. Jorgen Pillay, who is the Deputy Director General at the Department of Health. Dr. Ryan Roach, Deputy Chief Executive Officer at Discovery Health. You wanted to say something before the break.
I wanted to make the point, Xolani, that a critical issue around this rising incidence and prevalence of cancer is that we really need to improve our screening programs at a population level. And I've got some interesting data that in Discovery Health Medical Scheme, of all adult females in the scheme who are at risk of breast cancer, and we heard Kiara speaking about breast cancer earlier, only 16.5% have been screened for breast cancer. They've had mammograms within the last 2 years. So the guidelines is within 2 years, have a mammogram. Only 16.5%. So the vast majority of adult women, certainly in the private sector and Discovery Health Medical Scheme, are not being screened. What we're seeing consequently, and it's quite obvious, you spoke about your disease being stage 4 at diagnosis.
Yeah.
We're seeing that in 2011, about 12% of breast cancer was at stage 4 at diagnosis, whereas now in 2017 terms, 20% was at stage 4 at diagnosis. Of course, the earlier the stage at diagnosis, the better the chances of recovery.
Yeah.
And screening is critical at a population level for the whole country.
And Adri Ludik at Chok, you wanted to say something as well.
Yes. According to our statistics, our population, we should diagnose around 2,500 children annually with childhood cancer. Unfortunately, we only diagnose around 1,000 children. IARC reported in 2017 that childhood cancer increased in the past 2 years with 13%. So our biggest problem in childhood cancer is...
Let me understand that in 2013 you say childhood cancer increased by 13%.
In 2017. In
2017.
In the past 2 years, prior to the report, childhood cancer increased internationally with 13%.
Wow.
Yes. So for us, we can't screen children. The biggest thing that we can do is the early warning signs training on the early warning signs of childhood cancer. And then we need to speak to government about the referral pathways, because a child with cancer with children is usually in the developing cells. It's very fast growing cancers. So we can't go through the referral pathways that the health system dictates. We need to fast track our children with cancer to go quickly.
702.
WhatsApp Xolani on 072 702 1702.
It is 21 minutes now before 1, and we're still talking about cancer. What can be done? What prevention methods do we have in this country? Screening, treatment, is the public healthcare system in particular, and generally just the healthcare system, able to deal with the cancer epidemic in our country? All right, let me start by looking at one or two messages on my Twitter timeline. There is somebody called Owen Nosworthy who says the SA Cancer Registry has been inadequate for a number of years now. Only recently it became mandatory to report cancer by laboratories. There's also Mbongo who says all the Department of Health does is campaigning. 500 patients are on the waiting list for cancer treatment in Charlotte Maxege. What is the department doing to fix machinery and make available staff at the hospital for this work, besides the PILA campaign as well as announcements that they make ever so often? Zaki Matebula says, I'm so afraid and listening to you talking like this, and our government is like they don't care about poor people who are sick. There is also another message, or somebody called I'm a Woman, who says, please also discuss alternative non-chemotherapy if such exists. What I'll do is I will ask Kiara to also maybe touch on that. She's going to come through in a minute. Let me take one or two calls before I go to Kiara. In fact, let me start with a voice note, Chris, if we can.
Hi XG, it's Nigel here. Yesterday we were at Tambo Memorial. 4-month waiting list for a scope for a colonoscopy. Government hospitals. I mean, what will the stage of the cancer be in 4 months' time? Wow, it's bad if you don't even have medical aid.
Yeah, we'll ask Dr. Jürgen Play to respond to that. Let me quickly take Cliff in Mondio. Cliff, hi. Cliff is gone. Let me go to Cabo in Midrand. Cabo, hello.
Hello, how are you, Colin?
I'm good. Go for it, please.
Okay, Colin. My mom passed away, ne?
Yes.
And the hospital in Pretoria, they failed us whereby we saw that my mom was sleeping, doing all those things. They told us they fixed everything. All within 6 months, my mom passed away. And then I had 2 ectopics, ne? 2 ectopics whereby the doctors told me that I have to take all my tubes out because they're going to cause me cancer. And what I did, they took me to a pap smear. That's the simple way where the people can see that they've got these diseases. They have to go for pap smear. That discovers everything in your body.
All right, Cabo, listen, thank you very much. Let me just, if I may ask you, Kiara, to respond to what Cabo is saying. Do you know anything about it? But secondly, also just go back to that message from my Twitter timeline where somebody is talking about alternative treatment.
You know, there's a lot of, how do I say it, research in inverted commas about alternative therapy, which is something I try and educate people against, because while there might be research out there, not a lot of it is valid. I try and educate people more on complementary health, so using those things to get you through your chemo, get you through your radiation, your surgery, because it doesn't necessarily have to be the horror story it was 10 years ago. There's a lot of complementary therapies that can make that chemo a lot easier for you than what it used to be.
Professor Herbst, what would you say to that? And let me give you my example. So when Stephen interviewed me here, and obviously we made an announcement about my diagnosis, I promise you, I tons and tons of emails, right, from people pointing you in different directions. Because you're panicking at that time, obviously you're paying attention. And one of the things that came through the theme was that just don't do chemo because the survival rate is 3%. And a lot of people were quoting that. And I already had started chemo. And you know how confusing that is. Is there advice that you can give to people?
You know, I think I want to agree with Xolani that we also from the Cancer Association side say to people, be careful of just going for alternative treatment. Because there's really very little research, actually, pointing to the benefits of alternative care. And there's more research just pointing to the contrary, that it's unproven, it has no benefit, and actually some of them are quite dangerous. And complementary treatment for people who are undergoing chemotherapy especially, something that can assist them in preventing...
That's a very interesting. Complementary, would that include...
I just want to say something about your 3% chemo thing. That is an article that's gone viral all over Facebook. Social media is our biggest thorn when it comes to the latest cancer treatments because they promote a lot of treatments that don't work. And so I know people mean well, but they actually do more damage by giving that type of information than supporting their families or their friends with the cancer and helping them get through it instead of sharing bogus information with them. Complementary therapies can be anything from acupuncture. It can be massage therapy, reflexology. Please, when I say reflexology, I'm talking about a proper allied health profession, not the one at the little salon. And there's diet. Diet is a huge thing to get you through your chemo because I'm sure, as you know, there's times you don't want to eat. Everything just smells awful, tastes awful. And seeing an oncology dietitian can get you through that part and make sure you've got enough nutrients.
You know this argument, they even argue, and even the doctors, by the way, that there's research conducted, I don't know whether in South Africa or elsewhere, where you have over 50% oncologists saying that they wouldn't use chemo if they had cancer.
I would have to see that because the research I do is that a lot of doctors are behind the chemo and that. I would honestly
And again, I'm just referring to the emails I received.
Okay, so
So nothing empirical.
I know exactly where that comes from. Okay, there's an organization that has made themselves very well known through YouTube and social media that talk about alternative therapies. Because now that you said emails, I know exactly where it comes from. That information was an old paper probably done, I think, I stand to be corrected, but in the 50s or 60s where doctors, or somewhere around there, that doctors said they wouldn't have chemo themselves. It is a very old paper, but if you speak to oncologists these days, I mean, I've put my own family members through chemo. And I wouldn't have ever thought twice about it. So it's very old information. It's a YouTube series that's going around at the moment, and I've had to counsel 3 patients against following that advice because of the dangers it's going to cause. I haven't seen one successful case. I'm not saying there isn't any.
Adri, kids and chemo?
No, in pediatric oncology, we only use evidence-based and medically approved treatment. We use international tried and tested protocols, and these protocols are developed as a result of clinical trials in high-income countries, and it has the best care practice. So that is where we focus on, and all the protocols are specific to the cancers and are developed specifically for the children.
All right, Dr. Ryan Note, I'm going to come to you because the issue of the costs and approvals is a very contentious issue, and I've got an email that I want to read for you. But let me quickly hear from Dr. Jürgen Pillay first. I took a voice note here, Dr. Pillay. Somebody who says they were at Temba Center and they were told to wait for 4 months for treatment. Again, it goes back to my question earlier on. You have no time to wait. A minute is so valuable to you if you are a cancer patient that you can't wait for months.
No, fully agree. You were talking about Tambo Memorial, and I will be contacting them now that I've heard this story to find out what's going on. So I will give you personally, Xolani, some feedback on what's going on at Tambo Memorial.
All right. Okay. Listen, just let me know if you need to go back to the summit, because I understand that you need to go and talk to the summit. Let my producers know. Let me come back to you, Ryan. There's an email here. Somebody who says, I would like you to ask the Discovery CEO, Deputy CEO in your case, this question for me. If a treating doctor recommends a treatment plan based on the investigation that he has done, for example, he sent me for a PET scan, took bloods, and referred to the previous treatment to see what medication I was on for how long. How does a medical aid refuse to pay for medication like they were refusing to pay for Herceptin? Is the opinion for Discovery panel more important than that of the treating doctor? This process took like a month before they approved. At that time, the illness continues while I'm waiting. How does Discovery Medical Aid allocate the oncology benefit? Does it go down every year, or does it go up as the medical aid premiums go up every year? For 2 years in a row, my funds got exhausted by June. Those are two different questions.
Yeah, thanks, Xolani. The issue of cost is obviously a very contentious one when it comes to oncology. And I should say that the ethos at Discovery is to try and maximize cover wherever we can. The first question was specifically about authorizations. And so let me be quite concrete about that. At Discovery, we don't have the expertise to know which treatment plan is best, which is supported by new evidence. And this is a very dynamic environment where there is new evidence being released all the time. So we contract with an arm's length organization, which is the South African Oncology Consortium. It represents academic and private oncologists who together sit on a panel, and in this case practice what we call team-based medicine, as opposed to one person's opinion in a particular scenario. It's a team of oncologists that consider a case, and they give us a very clear recommendation on whether the treatment plan that's been proposed is appropriate and supported by the evidence, or whether there are alternatives that should be considered first. The tricky issue here is that it's not our role either to prescribe therapy. It is our role specifically to fund the therapy. So we base our funding decision on the recommendation from this arm's length independent panel of experts. There are sometimes disagreements between this panel of experts and a specific treating oncologist. And in those cases, we try and get them to talk to each other, which most of the time is not problematic. Although I should say, on the margin and in exceptions, there are some oncologists that refuse to take advice from a panel. And we try and do that for two reasons. One, it's in the patient's clear best interests. So it's not our role to interfere in treatment, but if there is an opinion that's different, let them resolve it between the experts. And secondly, we must make sure that the funding we allocate from the scheme, which is members' money in the first place, that funding must be appropriate, must be for the best evidence plan to give the patient the best chance at success. And one last comment here. Sometimes the panel will come back and recommend a treatment plan that's more expensive. We live and die by that recommendation.
I want to bring in Chiara. Please come through to the microphone, because you deal with breast cancer specifically. And there's a person who has breast cancer, and they're talking about Herceptin. I don't know much about it, but I would imagine that Herceptin, it's established that if you have breast cancer, you need this particular drug.
It's for
or not.
It's for a certain type of breast cancer, a HER2 amplified breast cancer, and survival rates are much better if the patients are given
But why
access
then
to
would
this drug.
Discovery quibble about giving this particular patient when a particular doctor has said Herceptin?
Yes.
Are you sure that it is a Discovery case? Because Discovery is...
It is written here, Discovery, and it actually has the name of the doctor, it has Herceptin, it has a patient...
And it's on some of the plans.
So Herceptin is covered on all Discovery plans. The cost of Herceptin treatment on average relative to non-Herceptin treatment, just out of interest as a data point, 335,000 Rand per patient versus 39,000 Rand per patient. So it's remarkably different. There are criteria. Those criteria are based on evidence and again supported by the experts. And those criteria relate to this human epidermal growth factor, the HER2 growth factor, which is tested for in the cancer. Where the cancer is positive for that, we cover Herceptin. Last year, in 2017, we paid out over 80 million Rand for Herceptin. And, that cover exists today. So without knowing the case in particular, and I should invite your listener to connect with me directly after the show, without knowing the case in particular, that is the situation.
But Kara, you want to say something?
But isn't that not dependent on the type of plan?
No, Herceptin is covered on all plans.
On all plans.
Okay.
Xolani Gwala taking your calls on 011 883 0702.
And I'm also looking at your emails at xg@702.co.za, xg@capetalk.co.za. Let me take this call from Dr. Brandon Burbington, who is a surgeon at Donald Gordon Hospital, who has called. Dr. Burbington, thank you for your call. Good afternoon.
Good afternoon. How are you?
I'm very well. Thanks indeed for calling. What are your experiences? What would you like to share with us?
Okay. As a colorectal surgeon, I can safely say that over the years, I've seen a gradual trend towards an increased number of black patients presenting at a young age with colorectal malignancy. This is an impression, and that impression has led us as a group to try and research colorectal cancer in the South African context. To that end, we've managed to acquire an MRC grant, which has enabled us to start collecting data on our patients. The hope is in the long term to get a better picture of colorectal cancer as it affects our community rather than individuals. And our data is slowly growing. And I hope that we'll be able to increasingly answer the questions that are going to become increasingly important to South Africans, namely, how is it that cancer is affecting South Africans as the population increases in age?
See, it's a spanner in the works in terms of the perceptions out there. I mean, the first thing that we need to deal with is that for the longest time in South Africa, people thought that cancer was a white disease. That's the first thing.
That's right.
But it's interesting that you're saying, according to your information and the studies that you've conducted, in fact, young black people present a lot earlier than white people with colorectal cancer.
Yeah. I can safely say that at this moment in time, the data that I am collecting does not confirm or refute that. But if you look at international statistics coming out of the populations across the world, in developing nations, the incidence of colorectal cancer is increasing as the years pass. So that information is best described by the IARC figures, which is indicating that across the world in developing countries, colorectal cancer is becoming, the incidence is increasing.
No, listen, thank you for the call. I really appreciate it. I'm going to keep your contact because we're going to have a lot of these town hall kind of discussions. Dr. Brendan Burbington, who is a colorectal surgeon at Donald Gordon Hospital. Maybe starting with you, Dr. Noja, and we're wrapping up here. Is it your experience? Do you concur with what Dr. Burbington is saying?
Dr. Burbington is being modest. He's one of the country's leading colorectal surgeons. Wow. He was my teacher when I was at university.
Oh, fantastic.
Colorectal cancer in Discovery Health Medical Scheme's experience is one of the top 2 cancers in both men and women on the scheme. In men, it's prostate followed by colorectal. In women, it's breast followed by colorectal. And actually, there are 171 colorectal cancer patients for every 100,000 members of the medical scheme. So in prevalence terms, that's a very high prevalence of colorectal cancer. The sadness, again, relates to the screening for colorectal cancer because, colonoscopies are indicated for men and women over the age of 50. Once,
but I was 42 when I was
correct.
diagnosed.
And now the American guidelines, I understand, are being considered to be reduced to 40 years of age. Although I'm not sure if that's published yet. I may be out of the loop, but that is my understanding. But just for interest, 2.3% of eligible adult males on Discovery Health Medical Scheme have been screened for colorectal cancer.
2.3. Professor Herbst, I need some sort of a parting shot here, something that people will take with them. What do we need to do? We're wrapping up. We've got less than a minute.
I just want to add something to the colorectal incidence in black people. If you read the literature, all the years, South African black people were known to have the lowest incidence of colorectal cancer in the world. And we're seeing a rapid change in this picture ever since the dawn of democracy. And where the diet, people moving away from their traditional diets and eating maybe more junk food, maybe becoming more inactive, not eating sufficient vegetables and a healthy diet and fruit, taking in antioxidants and minerals that they need from natural sources, which that contributes. I would really like to hear the outcome of the research from Donald Gordon.
We will certainly be on them, and they will make that available to us. Chiara, I'd like to get your last word.
So when it comes to treatment and chemo, that I advise patients not to be so terrified and to first see how your body reacts before you want to go and put a whole bunch of it's been tried and tested and proven to work yet.
Clearly, we couldn't answer a lot of other questions that are coming through. So what we'll do is we will schedule another discussion, and we'll certainly give people times, places where we'll continue with this discussion. But I must thank you all for coming through today and participating. I really, really appreciate your time.
Thank you very much.
Thank you very much. And thank you for listening to the show. And thank you for your contribution. Again, if there's anything that you want to bring to our attention, send me an email, xg@702.co.za or xg@capetalk.co.za.